Hi, good afternoon, everyone. I'm Valerie Wolf from OCal. I'm sure many of you have met me before, and I'm just want to welcome you here for our 18th OC COVID presentation, which is a series of webinars, as you know, that we've been running now for more than a year. To make the case and support the efforts of workplaces, recognizing that COVID is in fact an occupational illness and experienced in the workplace, and that workers need to be prevented, that exposure to workers needs to be prevented. And we're very happy today. Today's event is an intersection between another tradition that we run yearly at OCal, which is called October, which is about the occupational health and the prevention of occupational disease. And so they're kind of intersecting in this crossover event. And then there will be other October events, which perhaps Kimberly can talk about at the end, that we're going to start as a series at the end of this month on October 29th and then running through November. So there'll be another webinar session for the 5 weeks starting October 29th. But today I really want to welcome, we have 3 great speakers, and I think all the topics are focused on COVID, but they have a dimension that's relevant to occupational illness and occupational disease prevention in general. And so I think we will start now with Peter Smith, who's going to talk about data is the key to workplace and community prevention, and COVID as a case study. Kevin, do you want to introduce Peter, please?
Yeah, it gives me great pleasure to introduce Dr. Peter Smith, who actually happens to be a fellow Australian, but he's lived in Canada for 20 years, but he tells me he's been back to Australia for 3 years. So Dr. Peter Smith is a scientific co-director and senior scientist at the Institute for Work and Health in Toronto. He also holds appointments as an associate professor of the Dalai Lama of Public Health at the University of Toronto and in the School of Population Health and Preventative Medicine at Monash University in Australia. Peter's co-authored papers with our very own John Udick, and which is really, really great work. So I just want to hand everyone over now to Dr. Smith. Thanks, Dr. Smith.
Data and the key to workplace prevention. In terms of just some acknowledgements before I start, some of the work I'm going to present today was led by Sarah Buchan at Public Health Ontario, and the other research team members just listed there. And then a lot of the thoughts that I've had around information and the information gaps and how they might be addressed have been informed with discussions with Tish Davis in the US and Andrew Curran in the UK. We did a session last week at World Congress, which was talking about some of these information gaps, and I'll be touching on a few of those today, and I'd be more than happy to have a discussion about them in the panel at the end if people are interested. So in terms of just the background in relation to what I'll be talking about today, the workplace was identified as a potential location for COVID transmission relatively early in the pandemic. You only have to think back to the prescriptions about how if people needed to work from home, they should work from home unless they had to go into the office. So obviously the workplace from the get-go, people saw it as a potential site for COVID transmission. Yet despite this, there was really inconsistent data collection that would have enabled us to understand the relative contribution of workplace transmission compared to transmission in other locations. One of the things I'll be touching on a lot today is that the people who are going into the workplace, they've also, I guess, risk is continuous across settings. But it's important for us to be able to identify where transmission takes place in the workplace, because that way we can learn a lot more about primary prevention. And the way data has been collected in not just Ontario, but also in the US and the UK has really inhibited us being able to do that. So why should we try to understand COVID transmission at work? Well, as I said, the workplace provides an important setting for primary prevention activities. If you think about workplaces, this is where people from different communities come, they interact with each other, they go home to different communities, there's activities that take place, both getting to work and outside of the workplace, where the spread of COVID might happen. If we think about the workplace, the levers to prevent COVID transmission in a workplace setting should be easier to administer. So in terms of masking compliance, in terms of ventilation systems, these things should be easier to administer within a workplace setting because it's a site where employers have the responsibility to enforce these primary prevention activities and infection control practices. And as I said before, workplaces are settings where people from different communities come together. So it's a site where transmission could occur and then it could actually be exacerbated as those people then go back to those different communities. So in terms of the challenges of assessing COVID transmission at work, as I said, the risk is continuous across settings. So with COVID, we were faced with a situation where the transmission of the virus, if we think about the three routes through droplet transmission, through contact transmission, and we know that contact transmission is probably not a major source of transmission now, and aerosol transmission. These can occur in a variety of different settings. They can occur inside houses, they can occur in apartment buildings, they can occur as people go to work, they can occur in lunch break rooms, not just on the shop floor. And so we need to think about, there aren't really many settings where there's zero risk of transmission. Risk changes across different factors, depending on ventilation and the ability to distance from other people, as well as personal protective equipment, but there isn't really a setting where there's zero risk, and there is a continuum of risk that occurs across most settings that people are in. While we had historical estimates of labour force participation, this didn't really tell us who was still working. We had a lot of job loss at the start of the pandemic, and it didn't tell us who was still going to the workplace. So while there was some usefulness in looking at census data to determine who might be going to the workplace, it really didn't tell us who actually was going to the workplace. Our estimates of population of work-related transmission at the population level was really restricted to workplace outbreak information, and as well as a collection throughout the pandemic of information of positive cases if they were a healthcare worker or not. Although that information, that collection of information on a healthcare worker wasn't really focused on worker-to-worker transmission, but more focused on healthcare worker to client transmission. And in terms of the workplace outbreak information, cases in education, in healthcare, and in congregate living settings didn't distinguish from cases among workers compared to non-workers. So outbreaks were collected in healthcare from the start, but they were really just a sum of the number of people, both workers and clients, who had tested positive for COVID, with no distinction between who was a worker and who was a client. Same for education and same for congregate livings. So this made estimating the proportion of cases attributed to work quite challenging. So in terms of, this graph just presents the cumulative case counts of healthcare worker cases. So these are cases that occurred among healthcare workers, as in they assessed that this person was a healthcare worker when they, with a positive diagnosis, and among cases in the working age population. The healthcare worker cases are positioned on the left of the graph. The working age population is positioned on the right of the graph. There's a difference of a tenfold difference. You can see at the start of the pandemic, the increase in cases among healthcare workers, which is the blue line, was much steeper than the increase in cases among the working age population. You can see there was a sort of a flattening as we entered the second wave of the pandemic. And then as the vaccinations rolled out, again, a sort of a flattening among healthcare workers, which occurred much earlier than it occurred among the rest of the working age population. But in terms of healthcare workers, the ascertainment of that, and if they were working in healthcare settings, we didn't actually know any of that information. It was just that it was determined that this person was a healthcare worker with a positive case of COVID. So in terms of workplace outbreaks, which is the main source of information we've had to use to understand workplace transmission. So each public health unit is responsible for declaring outbreaks within their setting. And so automatically you've got a little bit of variation between some units, just depending on resources and size. Number of workplaces might be quicker to declare outbreaks or might be more able to declare outbreaks compared to other units. For an outbreak to be occurred, 2 cases within that workplace have to occur within a 14-day period, and these cases have to be linked to each other. So it shouldn't be possible for those cases. I guess if there's a possibility that the transmission has occurred outside of work, so where people live together or maybe travel to work together, that wouldn't be declared as a workplace outbreak. And the definition varied by industry during the pandemic, which has made it hard to interpret the workplace outbreak cases over time. So for healthcare, at the start of the pandemic, it was just one case to declare an outbreak, but then it changed to 2 as we entered into the second wave. And so the definition has changed over the pandemic in terms of testing, because the testing positivity rate has changed and the accessibility to tests has changed. It's also made it challenging to compare trends in the number of workplace outbreaks compared to just looking at them at a particular point in time. So what we have done is we did partner up with Public Health Ontario. So Public Health Ontario got around one of the limitations that I described before, in that they retrospectively assigned all outbreak cases across one of 13 industry groups. So they went into the outbreaks within healthcare settings, within education settings, and within congregate living settings, and determined which proportion of those were among workers and which were not among workers. Then they assigned them into 13 different industry groups. What we did is, at the Institute, is we went to the labour force survey, which starting in April had a supplementary set of questions for a proportion of the sample about where they were spending the majority of their hours. So were they spending it at the workplace or not at the workplace? We looked at the rates of workplace transmission across 3 different time periods: April to August 2020, September to December 2020, and then January to March in 2021. So what I'm going to present today is a standardized incidence ratio for each industry. And what this does is it compares the rate within the industry per hour worked to the overall rate within the working age population per hour awake. So when the standard incident ratio is above 1, that means the transmission at the workplace or within that industry is higher than the transmission in general is occurring. And when it's below 1, that indicates that the transmission in the workplace is below what is occurring in general among the working age population. Then one of the challenges is that over time, it always depends on how much the rate of COVID transmission is changing. So we're always, the reference point changes over time. But again, I'll try and explain it as best I can as I go through the slides, but if people have questions, I'm happy to come back to them. So this gives you a description. In the first blue shaded area on the left of this graph is the first phase of which I'll be presenting in terms of the information. Where it's white is the second period of time that I'll be focusing on, and where it's blue again on the right-hand side is the third period of time. You can see in terms of the 7-day average for all cases and also cases among the working age population, all cases are in blue. Cases among the working age population are sort of that goldy, yellowy line. It changed quite dramatically, that they were relatively small within that first period of time that I'll be focusing on, increasing in the second period of time, and then at highest during the third period of time that I'll be focusing on. So keep that in mind in terms of the incident ratios, because the reference point is increasing within each graph that I present. So this just looks at the proportion of cases and the proportion of hospitalizations due to workplace outbreaks among the working age population. Over the total time period, there was about just north of 282,000 COVID cases among the working age population between April 1 and March 30th, 2021. Almost 8,000 hospitalizations among the working age population. In terms of the proportion of those which are attributed to workplace outbreaks, about 12% of the total number of cases, about 7% of hospitalizations were attributed to workplace outbreaks. It was highest within the first time period that I'll be presenting. 23% of cases in that first time period were attributed to workplace outbreaks, dropping to about 11% for the other 2 time periods. In terms of this standardized incidence ratio, so at the bottom of this graph are the 13 industries that were where the workplace outbreaks were put into. The standardized incidence ratio, there's a log scale, so that's the y-axis is a log scale. just to make things fit within the graph. And the standardized incidence ratio is at 1. So where there's a dot above 1, that means that it's a higher rate of transmission per hour within that industry group. And whereas below 1, that means there's a lower rate of transmission than the overall rate among the working age population. Within this first time period, you can see very elevated rates in agriculture, standard incidence ratio of 25. We can talk a little bit about agriculture. That's the one industry where it's very, very hard to estimate denominators. It's quite easy for the numerators, but it's very hard to estimate the denominators because around working from home and then around temporary foreign workers, which aren't included in the labour force survey. Among education, among healthcare and social assistance, 9 times the standard incidence ratio, and among food manufacturing, 5 times the standard incidence ratio. And then there's a number of other rates which are below 1. Within our second time period, so keep in mind the overall rate has gone up now, but in terms of with reference to that overall rate, we still see elevated rates for agriculture, for healthcare and social assistance, and for food manufacturing. Again, 2.5 times the risk approximately for each of those groups. And within the final time period, again, we see agriculture at 4.3, healthcare and social assistance at 2.2, and food manufacturing at 2.4. And you can see over the right-hand side of the graph for transport and warehousing, a 1.5 increased risk within that time period. So just to summarise what we've learned from the workplace outbreak findings, so over the period of time from April to March 31st, about 12% of cases were attributed to workplace outbreaks, and about 7% of hospitalisations. In terms of rates of COVID per hour exposed, so thinking about per hour at the workplace or per hour awake for people who are not at the workplace, they were consistently higher than the general transmission rate for agriculture, for healthcare, and for food manufacturing. Again, the standardized incidence ratio, what you don't see within that graph, because it's always presented against the comparison, the rates per hour worked within each workplace was increasing at every time period that we're focused on. It's just that in reference to the overall rate of transmission among the working age population, the excess risk was going down. The majority of industry groups had rates of COVID transmission which were lower than the general transmission, which was about 75% of all people going to the work site. But the industries of agriculture, healthcare, and food manufacturing contribute about 20% of all workers which were going to the work site, and they all had elevated risks. So just to talk about some of the challenges with workplace data, which will lead on to the second bit. So workplace data provides some insights, but we could have done so much more in terms of better understanding the risk of workplace transmission. So as I said, the risk of transmission is continuous across settings. So there are situations for workplace outbreaks, you need to be definitive that that case did occur within the workplace. If there are situations where it could have occurred in the workplace, but it could have also occurred outside of the workplace, then usually that would not be classified as a workplace outbreak. So workplace outbreaks are likely an undercount of the number of cases of transmission which have occurred within the workplace. There's also within workplace outbreaks, and especially in large employers, there's a chance that there's a sort of an overestimate of number of COVID cases. So within large employers where there's an outbreak, usually every employee is then tested, which can lead to a lot of detection of asymptomatic COVID cases, which you wouldn't normally get within the community level data. There's likely a lot of variation across public health units in terms of workplace outbreak detections, in terms of the definitions they're using, in terms of the relevance of workplace outbreaks, and that needs to be taken into account. The ideal surveillance system has consistency in terms of data collection, and the extent to which that occurs across public health units in Ontario is unknown at this particular point. And it also doesn't include subsequent cases in the community. So there's a paper by Michelle Murdy from Public Health Ontario, which has done a good job of estimating at the start of the pandemic how many workplace cases went on to subsequently infect household members. And she suggests in that paper that you could probably inflate workplace outbreaks by another 50%. So in terms of the 12%, you could say there's another 6%, so about 18%, that are subsequent household infections that are due to a workplace outbreak. We don't know if that held constant through the second and third periods of the pandemic, but it was certainly within that first wave of the pandemic. That was the transmission they could work out from a workplace outbreak to a subsequent household member. So let's think about other sources. So workplace outbreaks are a good start, but they're not going to give us the exact answer we're looking for in terms of the overall proportion of how much transmission occurred in the workplace. You could think about COVID claims from the WSIB. Currently, there's been almost 28,000 claims which have been currently allowed for COVID-19, a few more that have been submitted and haven't been allowed or have been abandoned, and 8,682 exposure incidents. So that's where there might have been a COVID case in the workplace, but no subsequent submission of a claim for COVID has occurred. The good thing about WSIB claims is that they contain detailed information on occupation and industry, so we can understand a little bit more about occupational exposures, which we can't get even in the workplace outbreak data, which is by industry. We don't know the occupations for those positive COVID cases. We can identify claims within the same workplace because they've got the same workplace identifying number. Some of the challenges are that not all workers are eligible to submit a WSIB claim. Current estimates would be about 70% of the Ontario labour market is eligible for insurance or to submit a claim to the WSIB. And we don't know for COVID, but we know for other injuries and illnesses, and not all injuries and illnesses are reporting. In fact, for those of you who follow the speaker series at the Institute for Work and Health, and those who missed it on Tuesday, there was an estimate of the number of cases or number of eligible workplace injuries that are reported to workers' compensation. This was in British Columbia, and it's about 50% are not reported. So there's an undercounting problem here. We've done some recent estimates in Ontario, British Columbia, and Alberta, where it was about 60% were not reported. So there's an undercounting issue here. We don't know the extent to which it's happened with COVID claims, but again, it means that often we wouldn't want to rely solely on workers' compensation claims as a metric of injury surveillance. So other approaches that we might have used. So data linkage offers another opportunity, which was unfortunately not taken up in Canada. So had we had a large survey, such as the UK Biobank study, which has 120,000 participants with occupational information, we could have linked that to healthcare records and better understood particular occupational groups where maybe a proportion of COVID cases was higher or lower. Not that we could definitively attribute those to work, but if you see a particular occupational group which has an elevated rate, and maybe you can adjust for other socioeconomic or housing conditions, then you can get a better idea that, you know, if we've accounted for those other factors where transition may have occurred, we can narrow in on how much transmission was occurring in the workplace. Some of the challenges with these studies has been the timing. So the biobank data was about 6 or 7 years old in terms of the occupational information. So again, we don't know if those people were still working. We don't know if they were still in the same occupation. If we were to think about it, and also the biobank is not representative. It's about a 5% response rate in terms of the number of participants they wanted in the biobank study. So under represents more marginalised groups in society. If you think about Canada, I mean, the long form census certainly will get over the representativeness issue. It's a 25% sample of the Canadian population. It has been linked to mortality and hospital discharge information. It hasn't been linked to healthcare data because that's more of a provincial system, but it potentially could be. There's still this timing issue that is someone's occupation in 2016 representative of their occupation in 2020? Maybe for some people, maybe not for others. Were they still going to the workplace? Again, we don't know. But, you know, we could start to account if we had a linkage like that. We could rely on some smaller surveys like the CCF, Canadian Community Health Survey. We end up with pretty small sample sizes with those surveys. We don't have any large-scale representative population-based surveys. The labour force survey would be another possibility. But yeah, we're sort of scrambling here where we don't have these large surveys where they've collected detailed information on work that we could have leveraged to link to healthcare records. Capturing information on work from positive cases. So as I said, there was a question about if they were a healthcare worker or not. But why not ask, were you working? Did you work in the last 2 weeks? Did you actually go to the work site in the last 2 weeks? And what do you do? Even if we just had that simple information, we could have retrospectively tried to assign occupational classifications or industry information, but none of that information was routinely captured, which again, considering the workplace was recognised as an important source of transmission, why wasn't this information being asked when public health units contacted positive cases? Why didn't they want to know if the person was at the workplace in the previous 2 weeks? And why wasn't that systematically done across all health units in Ontario? In terms of the missing and unknown cases, so in terms of the acquisition, so acquisition information is captured within the positive COVID cases in Ontario. You can see here the red bars. So these are just the cumulative counts, the weekly counts within the positive cases in Ontario. The red information here is where we knew the acquisition information, so whether it was a close contact, whether it was due to an outbreak, or whether it was due to travel. The unknown is if they just couldn't figure out where the transmission occurred or it was unexplained transmission, and the blue down the bottom is where there was missing information. And again, you can see that at certain points there was a lot of missing information and quite a lot of unknown information. So while trying to work out acquisition is important, given how much missing information there is, why not just ask the questions about if they had been at the workplace and what they did? It might have, again, allowed us to retrospectively go back and better understand what was happening around potential workplace transmission of COVID. Workplace-based studies. So again, had we actively gone into large employers in essential workplaces, it really could have provided us with a lot more information on understanding COVID transmission. So had we been able to go in and asymptomatically test workers coming into the worksite from the start of the pandemic, we could have better understood where cases were linked to each other in the workplace. We could have understood common characteristics about work environments where COVID spread was high and work environments where COVID spread was low. It would have enabled us maybe to better identify early on some of the risks around airborne transmission, which it took a long time for this to be recognised by public health in Ontario. Effective and ineffective workplace prevention practices. So we might have understood very early on that cleaning was actually not the most effective way to reduce workplace transmission. The contact was actually not one of the major sources of transmission. And even rates of asymptomatic cases. So what were the rates of people attending the workplace with no symptoms who actually had COVID-19? Just looking at the distribution, so this is the distribution of workplace outbreaks. You can see this really skewed distribution where not all workplaces have outbreaks. This hasn't been adjusted for size, but some workplaces have these massive outbreaks where COVID transmission spread quite rapidly, and others have very low transmission. So taking the mean doesn't represent anything in this particular situation, because the mean doesn't, is not even close to the median. It's a very skewed transmission. So this has occurred from the start of the pandemic, and by better understanding what's going on in these workplaces where transmission's spreading a lot, obviously some of it's around viral load, about the ability to spread through air and through droplets, but there's also probably other things around the working conditions that have enabled COVID to spread a lot more rapidly in some workplaces compared to others. So the workplace did provide a unique opportunity. Had we gone into workplaces actively early, we could have learned a lot more about virus transmission, in my opinion. So some concluding comments. So from the beginning of the COVID pandemic, public health agencies in many jurisdictions, so we're not unique to Canada, but this has occurred in the US and in the UK as well, failed to collect the necessary information we needed to truly understand the role of work and workplaces in the spread of COVID-19. And that's even more surprising considering that the workplace was recognised at the get-go as a site where transmission was likely to occur. So I think the pandemic has shone a spotlight on the importance of work in health outcomes. Work is an important determinant of health, not just about work-related injuries, but it determines work in determines health status in many other conditions as well. We need to work now on better integrating the routine collection of work information in healthcare databases. We know in emergency department records, there's a flag about whether it's a work-related, whether this incident has occurred at work, and that's about transmission of funding between the WSB and the Ministry of Health. But again, if we could routinely capture occupation and industry, would be so much better at identifying claims or injuries that are missed by workers' compensation. And have occupational health and public health work more closely. So I think the COVID pandemic has forced that situation to occur, but we need to maintain those relationships and increase them in terms of the future, because there's a lot I think that public health can learn from occupational health within the role that the workplace plays as an important determinant of health. So I don't know if we've got time for questions or comments. This is my contact information if people have other questions, but I'm happy to take any at the moment, Phil, if there are.
Thanks a lot, Peter. That was very interesting and interesting, I think, parallels of that we need to understand a lot more about COVID in workplaces, but also about a lot of other occupational illnesses. Not just, it's highlighted a giant gap that hopefully we can fill. I don't know, I was wondering about StatsCan, and maybe I missed the reference to it, that there's such a dramatic difference between what on Quebec reports with respect to occupation and what Ontario reports to StatsCan with respect to occupation. Do you know if that is that a deliberate policy choice, or because they don't have the information to report, do you think?
Yeah, I don't know. I don't know that. So I've seen that data presented. I don't know that detail overly well. I guess my comment would be that it's one thing to ask people to collect the data. It's a different thing to mandate it and standardize it. And I think in the sense of occupation, given the large differences in the amount of missing data, there's an issue around, why didn't we from the start mandate, if we knew that the workplace was important, why weren't certain questions mandated for all public health units or all disease registries or all people looking at COVID-19 to examine? I've had to rely on these, sort of fairly weak ecological studies to understand, essential workers. We could have done a lot better job, I think, had we gone into trying to mandate the collection and standardizing the collection of that information from the start.
Thanks. There are a couple questions, and then we'll go to the next speaker. So Kevin actually is asking a question related to the letter on Masks for Canada, but about the opinion, and it's kind of relevant, I think, to my question, that of a national standard for data collection and metrics. And I don't know if you've been involved in any discussions for pandemics, but for other occupational disease.
Yeah, so I do think, better, I mean, at the very minimum, I think all healthcare databases, we should be working now to try and move towards the standardized collection of at least occupation and industry within all healthcare databases.
Mm-hmm.
It'd be useful in emergency department visits, it'd be useful in all sorts of healthcare administrative data, both on disease and not disease. I mean, the point, it's sort of hard as in when do you collect the information? But, it's possible to collect, and it's possible to, I'd like to see better alignment between the administrative healthcare records and, Stats Canada around the collection of, and standardization of occupation and industry information, because you think about how powerful that would be, even to know as a piece of information, what sort of occupation did someone do? I mean, just to look at it over time to say, well, this health outcome tends to seem like people in this occupation tend to get this more. Maybe we should think about this occupational exposure. For most people, they'll spend a third of their working age time at work. Why aren't we collecting more information? And we know it's a determinant of health. Why aren't we doing a better job to understand the role that work plays in a lot of these situations?
Okay, thanks. I think there's one more question, and then we'll switch to you, Nir. And it's around education, and I was actually going to ask if you're following the whole schools issue and the continued denial by governments here and across the country about school transmission versus community transmission. But Dorothy asks, having heard someone from U of T on the Kitchener radio today saying that about 4% of education workers, based on a survey of 3,000 people in Ontario, I'm not sure if they were teachers entirely or not, had COVID, which this person, I think on the radio, said was not higher than others in the general population. But how does this jive with your findings? I don't know if you've done any studies related to the education sector.
So we have done, well, so we have done some studies with OCAL and with EDFO as well, thanks to the work which EDFO did in terms of facilitating that, where we've collected information from about 5,000 education workers in Ontario at the start of the pandemic. That was not so much to determine rates of COVID-19, but that was more to determine things around the provision of PPE and infection control practices and how they were linked to anxiety. And similar to other studies on healthcare workers and non-healthcare workers, we found that there was a failure in terms of some of the key infection control procedures that were occurring within education settings, and that was producing a lot of anxiety, which you can completely understand among education workers. In terms of estimating, again, the workplace outbreaks, yeah, as I said, so going back to the standard incidence ratios, you can see that education was about as it was for the community average. But again, it's, you know, I think the workplace outbreaks information is a start, but I don't think it's a definitive answer for the reasons that I described. And so it's hard in a lot of situations where, you know, to determine, so that's where the transmission has definitely occurred in the workplace. But if, you know, those people said, oh, we would travel together or we had lunch together, well, they would rule that out as workplace transmission. So I think it's challenging. I guess at the moment, I think it's important for everyone when they're talking about rates of COVID transmission in the workplace to acknowledge that, to be honest, we haven't collected the data for anyone to be definitive at this point around how transmission occurs. We need to go back to just understand the limitations in our data and say, well, this is what we've currently estimated, but this is why I'm not going to get up and say that the rates in education are nothing to worry about.
Great, thank you.
So much, Peter. And I did put a link in the chat box to a really interesting report produced by the Institute of Work and Health. It's response to COVID-19, gathering experiences of OH&S authorities in developed countries. So you might want to look at that as well.